Hello, everybody. Welcome back. Delighted now to have this opportunity to introduce a friend, a colleague, a person that I hold in the highest esteem, and been just a leading light. I would say this woman is the world's leading light in terms of normal birth and cytogenic theory, and she's the most humble human being I've ever met. This is Professor Soo Downe, and she is a Professor of Midwifery Studies in UCLan. And her main research is the nature of and cultures around normal birth. She's currently working with the World Health Organization on a range of maternity care guidelines. And she's been an author in 3 of the Lancet series, Midwifery, Stillbirth, and Reducing Caesarean Section. And she's a co-editor in 2 of these. She's published over 120 peer-reviewed papers, and she's undertaken research using a wide range of qualitative and quantitative methods, and just an unbelievable person. And I'm so delighted, Sue, that you could spend time with us after being up at 5 o'clock this morning teaching and sharing your knowledge across the globe on Skype. Delighted to have you. Over to you, Sue.
Thank you, Marlene, for such a lovely introduction. And I know you were up before me, so so I can't claim any kind of superiority in terms of the getting up early piece. I'm just making sure that the light's not too bright behind me. There you go. Okay, so what I'm going to talk about today is not directly breastfeeding, although I know that's the topic of the conference today. But I'm hoping it's a kind of research method that might be useful to some people. Interestingly, when I first started talking about this at the DMRS some years ago, it really was quite a new technique, but I actually think now it's much less so. So I suspect that quite a lot of you who are listening to this will have done a metasynthesis or even several. So some of the methodology might not be quite so unique as it might have been a few years ago. But I think what I'm hoping to do is to illustrate how it's been applied recently. So how metasynthesis and qualitative evidence is beginning to make a really big difference to care around the world internationally. And I'm starting really, well, the whole focus is around antenatal care. So again, you may say not much to do with breastfeeding, but that's because that's where we started with all of this in our engagement with WHO. So as I'm talking, I think that what I'm hoping is that you can think about how might that apply to your research in breastfeeding or your practice in breastfeeding or whatever you want, however you want to use the data on the one hand. And on the other hand, it's generally just a kind of upbeat presentation, I think, about the fact that qualitative research, and therefore, to an extent, I know midwives don't only do qualitative research, we do randomized trials and surveys and things as well. But certainly this part of the kind of research that midwives do, which is much less prevalent in other areas of maternity research, particularly when it's done by the medics, this particular area is beginning to gain credibility and take its place, if you like, in the way in which evidence and knowledge and therefore practice is constructed in the world. So the picture on the front, and I'm sure you all have seen this before in various oh, sorry. Yeah. Let me come back to, oops. You're all right. I just need to, I've unfortunately lost my cursor, so I can't do anything at the moment. So, it's back again. Hooray! Just took a little bit of a break. Okay, so, all righty-ho. Got that, so let's put that on. So many of you will have seen this picture, and I suppose the question is, who, maybe even in the chat box, if you've got access to the chat box, just for a second or two, who sees an old lady in this, or a witch, as some say, and who sees a young woman, and who sees both? Just if you've got access to the chat box, just, and if I can see your chat box, I think I can now, but it says chat disabled, so I'm not sure I can see your chat. So we'll just leave it as, no, okay, that's fine. So we'll just leave it for you having a look at that and thinking who sees an old lady, who sees a young woman. And then if I just illustrate that if you're looking at a young woman, you've got, this is her chin, that's her eye, that's her nose, this is her ear. You get your eye into the young woman. And then if you're looking at the old lady, this is the old lady's nose, this is her eye, this is her mouth. So the point being that you can look at exactly the same data or exactly the same phenomena, and it can be seen differently, completely differently by different people. So the kind of theme running through this, if you like, is how do we make sure that what we see when we look at data is what matters to women? So the whole range of people that have contributed to this presentation over the years, we've kind of between us all built it up. So some of these slides are from WHO and some are from work that we've done, and some are from other people's input at various points. So just to acknowledge them. So the critique, I suppose, is this critique of a standardization of care based on this kind of short-term effectiveness. So this is a particular paper I pulled up, which basically argues that guidelines are about doing the right thing every single time. But of course, the right thing is a bit fluid sometimes, and particularly if guidelines become rules, which they're not supposed to be, we end up with a whole range of problems. And part of this paper is about saying you need reliability. Well, yes, but you also need flexibility. And the kind of key example for this, I suppose, is epidurals. So there's no debate. Epidurals are the most effective form of pain relief in childbirth. No debate, really. I mean, they just do manage pain best when they work well. But the problem is that actually that's not the whole story in terms of labour pain. Labour pain is not just a toxic sensation. It's a complex adaptive process in terms of labour itself. And, you know, to an extent, you could argue that about some of the factors around breastfeeding as well. And this particular study highlights the point that actually there's a lot we don't know about this phenomena. So although there's a whole line about, oh, well, why wouldn't you give women epidurals straight away? It's cruel to deny them that. When you look at the phenomena of labour pain, and I'm not talking about pathological labour pain here, of course, I'm talking about physiological labour pain, then this particular study, which was done by Ulla Wardenstrom and her colleagues in I think Norway or Sweden, or one of the Scandinavian countries she's based in. So they looked at women who had a recollection of intense pain at 2 months. And then they looked at them again at a year. So all the women that said they had their labour pain was their labour was very intensely painful at 2 months. And then they looked at them again at a year postnatal. And at year postnatal, the ratings were different. So even though at 2 months they were all the same, by 1 year postnatal, those with epidurals persisted in having a rating of intense pain. Whereas those who had not had an epidural, generally speaking, had much lower pain scores, even though they'd had the same at 2 months. So one of the things that the researchers hypothesize is that there's an evolutionary, again, this won't be a surprise to people, an evolutionary pathway that allows women to forget labour pain, to be amnesic for labour pain, because if they don't, then they probably won't have another baby. And I apologise for anybody who's pregnant currently, as far as this is concerned, But for those women who have an epidural, it seems that the notion that the memory of intense pain is fixed. It doesn't seem to go away. So particularly if women have very intense pain. So that's interesting, because it means that, yes, it's a very good form of pain relief, but does it have other kinds of long-term consequences, apart from the physical ones we know about, that we haven't yet understood? So one of the perspectives that we tend to take in our team, and many people that we work with, is this notion of salutogenesis. So understanding not only what goes wrong and what might help what goes wrong, so in this case epidural for pain, but also understanding what might go right, that actually pain might be, if it's physiological pain, a complex adaptive phenomena, which is actually about health and well-being. In fact, you know, it's a component of the neurophysiology of labour, and that if we don't understand that, we might miss that actually being able to do what Antonovsky says, who's the guy that invented this salutogenesis idea, or developed the idea of the salutogenic theory. He basically says that if an experience is comprehensible, manageable, and meaningful, then people can cope with it, and it becomes a positive experience. So, you know, translating that into breastfeeding or labour pain or antenatal care, whatever it happens to be, if we can make that experience comprehensible, manageable, and meaningful, then even if from the outside it might look difficult, and I was just caught the tail end of the presentation around breastfeeding and fitting, for example, it might well be that there are other things that are at play here that we're not really necessarily picking up unless we look at them more closely. And Antonovsky talks about, why don't we think about a salutary factor as well as a risk factor? What might make something go well, as opposed to always thinking about what might make it go badly? So, and I'm sure you're all familiar with this statement about what evidence-based medicine is. This comes from Sackett and Guyot, who are the originators of evidence-based medicine. And what they say is that this is it's not just the randomized trials. It's actually a combination of best evidence, whatever that is, with clinical expertise and patient value. They're talking generally, when they use the word patient here, across the whole of medicine and healthcare. And basically they say, if you get all those things together, then you get the best possible outcome. So it's that combination. It's not just what the guidelines translated as rules based on RCTs say. It's a much wider phenomena if we're going to do evidence-based care. And this is a very useful paper if you're interested in this area. Pettigrew and Roberts, quite a very old paper, 17 years ago, they published this, basically saying, yeah, I mean, trials are fantastic. Nothing wrong with trials if you're answering the right question. But if your question is about, for example, acceptability, then actually you need qualitative research or surveys. You might need trials, but they're really not very good in that regard. So actually, it's horses for courses. The evidence that is required for the particular question that's being asked. So then when we start looking at qualitative evidence and bringing it all together, creating meta-syntheses of qualitative evidence, and again, this is much more acceptable now than it used to be, but there are still purists who would say that qualitative evidence is particular to the particular circumstances in which it was gathered, and you cannot add it up. You can't add up qualitative study A with qualitative study B, because that's completely philosophically unacceptable. It violates the philosophical principles of qualitative evidence in terms of its nature. But others say, well, but actually, if you don't add it up, then qualitative evidence ends up just in a kind of separate silo that nobody pays any attention to, particularly policymakers. So actually, we have to grasp the nettle here, and say, well, there may be some limitations to this, but actually, if we really want to understand what's happening with people from the perspective of qualitative evidence, we have to look at it across the piece. We can't just isolate it. So we've used this term knitting smoke, this idea of knitting smoke. How do you bring things together? And part of the problem is that actually when you start looking at any kind of systematic review, actually, what happens is, I think it's what Thorpe says, the meaning slips in and out of focus. It's really difficult when you're doing any systematic review, those of you who've done it, to keep a focus on your question, because there are always other interesting things you want to pursue. There's always rabbit holes you want to go down. So you have to be very focused on what you're doing when you're doing meta-synthesis as much as meta-analysis, to make sure you keep a focus on the topic. The classic text is this one, Noblet and Hare. There are other ways of doing, there's all kinds of meta now, meta-narrative, meta-method, meta-synthesis, meta-analysis, lots of different metas. But from the point of view of the kind of techniques, Noblet and Hare, very easy to read, very well worth having a look at. Who talks about meta-ethnography, although in fact in their study they involved far more than just ethnographic studies. They had a whole load of studies they combined. So our first published meta-synthesis was actually in 2007, but there have been others just before us, but it was still quite new at that point. And then the catalyst really for our engagement with WHO and for WHO's engagement with qualitative research, although they had already started to do it, was in 2013. And we published this particular paper. And the reason that I think that it was picked up, and this kind of the story I'm going to tell here really illustrates serendipity, that actually sometimes the stars align and individuals just click together, and then all kinds of things emerge as a consequence of that would have been possible before. And this is complexity theory, tipping point theory explains this very well. And actually, it doesn't happen by magic. You often have to set up a whole load of initial conditions over many years. So 2007 to 2013, as you can see, is what 6 years worth of effort, but there was effort before that as well. And then likewise at WHO, there were other things going on. So for a couple of decades, probably people have been working a bit in the wilderness on this idea of qualitative research with nobody paying any attention. And then the stars align and it all comes together, and suddenly you get this amazing tipping point. So I want to talk to you a little bit about this study because it makes the point, and again, we're not, I'm not claiming we're the only ones to have done this kind of thing, but this is about creating confidence in qualitative research. And at the same time, there was another team in Norway who were doing something similar to create confidence in qualitative research I'm going to tell you about, which became this moment of synergy. So what we did in our particular study is we said, okay, why do women in low-income countries not use antenatal care? And we hypothesized this might be because the way that care is provided might not fit with the social and cultural norms of people in those settings, some of the people in those settings. And that is actually what we found, having been very reflexive and making sure that we were not just finding what we expected to find. So we found that the assumption of the system, the assumption of antenatal care provision, is that pregnancy is potentially risky, so you need to go and have the care to make sure you're not having problems. That it's a positive social state, that everybody is happy to be pregnant, that's great, everybody loves that, the idea, and that women and families have enough resource to make rational decisions economically to access antenatal care, that you've got the bus fare and you can get the childcare and so on and so forth. And what we found from the qualitative evidence is, although that might be true for many, for those who don't use antenatal care, actually in low-income countries, lower middle-income countries, pregnancy is seen as a healthy state. So why would you go? Why would you go and have medical care if pregnancy is a healthy state? Why would you do that? So they don't go. But there's also, in some groups, an assumption that pregnancy is socially risky. That if you disclose your pregnancy, you're going to get an evil spell put on. You're going to get a spell put on you, or the evil eye put on you. And the last thing you're going to do is tell people you're pregnant before you're absolutely sure this baby's stuck, is safe in the uterus. So the last thing you're going to do is rock up to an antenatal clinic. Why would you? Because everybody will then know you're pregnant, and then you're at risk socially. And then finally, the difference is that actually for many of the women in these settings, they haven't got the economic capacity to go to these places to access antenatal care, because it's 2 days away down rough roads with a difficult bus ride they can't afford. They're going to get attacked by wild animals possibly if they go, and they'll be leaving their fields for 2 days, so there's no food for the family when they get back. So why would they go? So we said, based on the qualitative evidence, that may explain why women are not accessing antenatal care. And then equally, when it comes to why once they've been why they're not going back, well, the assumptions are that ANC is affordable, that the staff attitudes don't matter, and that women have, and that the antenatal clinics have all the resources that are required when women get there. And in fact, women's experiences are that when they get to antenatal care, they're asked for backsheesh for bribes, which they can't afford, that the staff are discriminatory when they get there and they're mistreated, the women are, and that also in the clinics that the resources are not available. There isn't the kit and the drugs and the equipment. So again, why would they put themselves through that? So they might go once and then not come back again. And so therefore that was the conclusion that, because we're not paying attention to what women are saying, then actually we might think we're providing what they need and want, but we're not, and therefore they're not using it. And this is just a logic diagram of that finding. So WHO, as I say, at the same time, we're developing a way of assessing the quality. In fact, it was Cochrane, Norway, that was doing this, developing what they call the SERQUAL assessment. So those of you who know Cochrane reviews and have done grade, this is a grade SERQUAL, which is used for qualitative evidence, for qualitative reviews, to be sure about the quality of the qualitative reviews. So it's a way of saying, how confident are we in the findings from this qualitative review for the population that we're interested in? So at the same time as we were coming up with this quite kind of logical way of looking at qualitative research, Cochrane Norway were coming up with this very logical way of looking at the confidence. And they produced this document. This is the very first WHO output that actually included qualitative evidence. And you can see 2012, just a year before our stuff came out. And that was Cochrane Norway, Claire Glenton and Simon Lewin. And also at the same time, WHO were producing a new quality of care model for maternity care, which integrated both the provision of care and the experience of care. So again, this kind of idea that the experience was really important, it was just kind of hanging around in the ether. And that was published in 2015. So all of these things were happening within 2 or 3 years of each other. And then there were the parallel developments that I'm sure you all know about in terms of where qualitative evidence might be used, and Cochrane Effective Practice and Organisation of Care, which had run out of the Norway Centre, was beginning to bring qualitative evidence into the mix as well. So the normal guideline process for WHO is you do these things you can see here, you define the scope, you set the guideline development group up and so on. And at the early stages, up until very recently, that was all done by experts, inverted commas, so clinicians, professionals. And in fact, for the antenatal care guideline, the first time we presented the qualitative evidence to the guideline group, it was largely white, middle-class US obstetricians that were in the room. I mean, not solely, but to a very large extent. So they were deciding what was the important questions to ask, what were the important questions to ask, what were the important outcomes to measure, and what was the quality of the randomized trials they wanted to include. So you can see quite a narrow concept of what might be important to examine and to measure. But actually, in terms of the guidelines, they do actually take into account more than just the benefits and harms, the RCT bit. There was also consideration of resources, values, acceptability, equity, and feasibility. But this information was really coming from expert opinion or the occasional trial, the occasional study they could find. It wasn't being done systematically, even though it's important they were considering those things. So the antenatal care guideline as I said, the existing guidance was only really on complications, no guidance on the routine care of healthy women and babies. They'd introduced the focused antenatal care model. 4 antenatal contacts was advised, but only just over half of women had that. Maternal mortality obviously very high, and guidance needed to be applicable to many contexts. So the aim was to actually say, okay, what do healthy pregnant women need in their normal care to allow them to thrive, not just survive in pregnancy? And again, that notion of survive, thrive, transform was beginning to get into the ether. This process, the synthesis process, what is now called QES by Cochrane, EPOC, and by WHO. We have some discussion about whether that's the right thing to call it, but that is what they call it anyway. So the process became and was done for the first time in the antenatal guidelines, to first of all systematically find the qualitative studies, assess the methodological limitations of the individual studies, to summarize them, synthesize them, and then to assess the confidence in their methodology, their relevance, whether all the studies involved were telling a coherent story or not, and how far the studies that are included are adequate. So you may have, for example, a qualitative finding with 25 studies that are all very methodologically highly relevant, highly good quality, that are all relevant to the question, that are highly coherent between them, but they were all undertaken in the UK. So they're not adequate to tell you anything about what might be the case in Kenya, for example. So each of those 4 criteria are applied to the summary of the studies, not the single studies, summary of the studies, to say, can we be confident in this finding for the populations that we're interested in, that in this case are global, particularly lower middle income. So as a result of the first piece of work that we did, we published this What Matters to Women Scoping Review. And the important thing about this is it wasn't about what women's experiences were. It was phenomenologically, if you like, what matters about antenatal care. So if you were trying to translate this to breastfeeding, it would be, what is it about breastfeeding that makes women love it so much, if you like, if they do love it, of course, or hate it so much if they hate it. But what is the phenomena of breastfeeding as far as women is concerned, and what does it mean to them in terms of being a mother, or in terms of of support of doing something for their baby, that we need to pay attention to when we design a service. So not having designed the service, what do women think? Is how do we design a service that's based on what matters to women, the other way around. So the 38 studies from a range of countries, as you can see, and quite a lot of women, and you can see the Wordle at the bottom there, which came out. And I know you can't see this very clearly, but this is really the point about this slide, and most of these slides are WHO slides that they've been using around the world to implement this finding, is that our summary finding was positive pregnancy achievement, that what women want was positive pregnancy achievement and maintenance of optimal health and psychosocial well-being for mother and baby. That's what women wanted. They wanted a positive pregnancy with optimal health and psychosocial well-being, even though sometimes it might not go as well as they might like. And you can see here the sub-themes, you can see the studies that the sub-themes come from, you can see the quality of the sub-themes in these grades, quality of the individual studies, I should say, from these grades, and you can see a comment here. So it's you can track very clearly where that information has come from. We haven't made it up, basically. And the finding was that women, as I just say, this is what they valued, and what that meant was maintaining normality where they could, maintaining a healthy pregnancy, obviously preventing risks and illness and death, effective transition to positive labour and birth, and achieving positive motherhood. And what's interesting about this for us is that when women talked about antenatal care, the experience of pregnancy, they were thinking already about motherhood. It wasn't, antenatal, intrapartum, postnatal. It was a whole system, a whole episode concept. And we framed it around Maslow's hierarchy of needs, as you can see here, basically saying that current antenatal care tends to be here, physical and physical needs and safety. But actually what women were talking about was, yeah, of course we want that, but we really want all this stuff too. And that should be built into the antenatal care provision. It shouldn't be left to one side. So this is just this is the Wordle again, and you can see this is about care and care provision. This is about support for cultural and social needs and wants, and this is about information. Those are the kind of parameters. So they were operationalized within the guideline like that: support, information, and effective practices. And you can see here the confidence is high because large numbers of studies contributed to the findings from a range of different settings. So not only did the findings become integral to the guideline decision process, we added a new outcome to the whole, we added an outcome to the outcomes that matter in terms of benefits and risks, which wasn't there before, which was a positive pregnancy experience. And it also informed the design of the model with those 3 components, and it informed the title of the whole kind of philosophy of the guideline. So, and this is a WHO slide, it's not what we said in our team, but what WHO said, that outcomes that are important go far beyond ANC coverage, stillbirth, attendant, and mortality and morbidity. We don't have much evidence from trials about the issues that matter to women, and pregnant women are considering their whole birth experience and effective mothering. So that's a WHO statement that comes directly out of the qualitative evidence. And obviously we could add much more weight to these aspects of the guideline now because we had the qualitative evidence and it was strongly there. And we also then were able to do some reviews on what factors influence the uptake of services. So this is now the experience and the provision of services. So that could then be built on the back of what we had said about what matters. As part of the whole process, we also did a review of providers' views and experiences using a similar process to do that. And again, this isn't going to be a surprise to you, but the outcomes were that the capacity to provide the kind of high quality relationship-based, locally accessible ANC that will facilitate access by women depends on sufficient resources and staffing and time and privacy. But what might be more important, or as important, is we also were able to say such provision depends on the organizational norms and values that overtly, explicitly value kind, caring staff who make effective, culturally appropriate links with local communities, who respect women's belief that pregnancy is usually a normal life event, but who can recognize and respond to complications when they arise. Now, this is the piece that most organizations miss. But we were saying, and we still say this is critical. And then obviously health, training and education and salary is all important. Particularly salary is important in low-income countries because one of the reasons why health professionals demand backsheesh and bribes from women is because they're not paid properly. So I'm going to just skip that slide actually, because that's probably less interesting. But what it might be interesting to know is that one of the outputs of this, one of the concrete outputs of this, is a recommendation for midwife-led continuity of care models, which was not in the previous recommendations, on the grounds that captures some of these aspects that we've just been talked about that are more psychosocial, as well as capturing safety, promoting safety. Group antenatal care is also in there, as is women carrying their notes, all new in terms of this phenomenon, this aspect. I'm showing you this slide, though I know you can't read it, but the reason for that is this is in our Epoch Cochrane publication around all this stuff, but it's also been used to implement these guidelines in practice. And apparently this was done in a number of countries in Africa. We weren't involved in the implementation piece, but what I've had back from WHO is that this logic model, which is based on the behavioral change theory, so we explicitly theorized our data by the behavioral change theory. These logic models really spoke to those that are working in low-income settings in terms of antenatal care. And each statement in here is based on some data with high confidence, or at least moderate confidence, from our review. So it can be directly tracked back. You can actually track that back to specific studies in the review. And the people on the ground found it really useful to plot where they were in the behavioral change or reason behavior logic diagram, in order to be able to help them to design new ways of doing antenatal care. So that was really quite I really like the fact that the theory actually works. So what makes it different? This is again WHO saying this, not us. So it actually provides ways of finding out what women want and need, what their views are and experiences are, and what healthcare providers' experiences are. It helped to identify meaningful outcomes and important interventions, influence recommendations in the areas that I talked to you about, influence the model of care that's actually now being implemented, influence the implementation considerations, how it was implemented, and frame the overarching guidelines. So the overarching title is Antenatal Care for a Positive Pregnancy Experience. So that women, what matters to women is absolutely front and central now for that guideline, and in fact others that have followed. So, and this is a comment from Ban Ki-moon on the back of the guideline. And since then, we've been very honoured to be involved in a range of guidelines, but specifically, most importantly, the intrapartum ones for a positive positive labour experience, and the postnatal one, which is about to come out early next year, for a positive postnatal experience, where there's going to be more, obviously, in terms of the kinds of things that may be of more relevance to people on this call, perhaps, if breastfeeding is your area of interest. But what's threaded through all of those is this notion about integrating qualitative research, and then there's also the one on optimizing caesarean section, which has got the same philosophy underpinning it and the same way of collecting qualitative data. So qualitative evidence has changed the conversation in ways that is not just about talking differently, but is actually about physically on the ground changing the way that care is provided, particularly in low and middle income countries. Oh yeah, this is a summary of the range of guidelines. So these are the ones that we were involved in, this one, and this one. And these are the ones that the Norwegian team have been involved in. And then the postnatal one will follow on. There's another one on uterotonics, actually. I think we might have been involved in that. Yeah, we were involved in that one, that's right. We're also now currently working with WHO on a whole part of a programme which is looking at mistreatment, verbal and physical mistreatment well, actually all areas of mistreatment. We're doing the verbal and physical of women in childbirth, and they're also about to do one on ultrasound. So there's a whole load of things coming out around this. So I suppose the question really to leave you all with is, how might this be used in the area of breastfeeding? Not specifically to do with WHO, but how can this kind of way of thinking about evidence be used to change the conversation around breastfeeding where you work and more generally? So that's the end. I'm not sure how long that was, but over to you for any questions or comments or thoughts or anything else you might want to put in the mix.
Oh, Sue, I was busy talking to you there. Sorry, I didn't realize that I was muted. Sue, oh my goodness, as always, you challenge us, yeah, and you make us think very deeply. And I really loved the way that you demonstrated the time that was required, the synergy, the lining up, the steadfast attention to detail and working for years and believing and valuing the research evidence, and then what's come out of it and how it has been now developed, molded, shaped, used, applied. It's unbelievable, and it is challenging for this team here, and I do hope that there will be some outcomes. Thank you very much, Sue, and I have a few questions for you here. Helen Batson. Professor Sue, do you think anyone involved in educating parents should have a qualification on how to teach, or should education be left to whoever is free to fill in the time slot?
Gosh, that's an interesting question.
That's a very interesting question. I think it's a very interesting question.
It does depend. I mean, you can, as with everything, you can have people who are naturally gifted at things and do a really good job without necessarily having a lot of teaching and training, and then you can have people who have been taught and trained who are really bad at the job. So my general point, obviously I'm going to say yes, it's great to be trained. It would be ideal that people were properly trained and educated to do any job they do. But that doesn't mean that somebody who's a naturally good speaker or a naturally good educator can't also do a good job. I think there'll be a problem if it was regularly left to people that had absolutely no training or education to do a particular job. That would be a problem. But I think in the mix, in the overall mix, you can have a range of people with a range of skills and qualities and attributes that can kind of fire people up and provide them with interesting information. The risk would be if you had somebody who was not trained, who was just imparting what they believe as opposed to what the facts are. And of course, we know very much and very currently what that leads to if we have people who are propounding things that are not based on fact. That is a problem. But the capacity to put evidence over in ways that are engaging, the ways that are engaging. Sometimes that's about personality and sometimes it's about training.
Very good answer. Thank you very much, Sue. Just in terms of language and the problems that are associated with language when you're working at that higher level, could you say a little bit about the challenges and the ways or approaches to dealing with those problems, particularly the language and getting the papers and understanding them and thinking about it's not necessarily a sense of coherence, it's about conceptual equivalence across the cultures.
Absolutely, and this is one of the areas where the purists go, whoa!
Yeah, they do. I hear, yeah. So just wanted to hear a wee bit about that because it is quite interesting. Please.
It's very interesting. Yeah. So as I've said, we have most of our papers, not necessarily all of them, but most of them, we have a principle that we include every paper in every language that we think is relevant.
Mm.
Now you can when you're going through the selection process, you can put titles and abstracts into Google Translate, and it's pretty accurate. So you can, at the point of going through, in terms of the headlines, so as you're going through that selection process before you get to the full text,
Mm-hmm.
you can be pretty sure whether the paper is generally in your pot or outside your pot. Once you get to the full text, that's when the conceptual nuances become much more meaningful, much more important. Now, obviously, we have the luxury when we work with WHO of having a whole range of people with a whole range of linguistic skills. So they will just, if we can't translate it in our team, then they will translate it, and then we can look at it.
Good people to work with.
Yeah, absolutely. But so when you get to, but then there are always some that can't be translated. Serbo-Croat or whatever, Hungarian or whatever. Because I hope if anybody on the call is Hungarian, I don't mean that Hungarian is difficult. I just mean not many people speak it. But so in that case, we will say we could not translate this. There is this paper, but we could not translate it. So it's pending. And that you would do the same with the randomized trial, actually. If you couldn't get all the data on a randomized trial, that's what Cochrane does. So you would say, okay, we've got 3 studies here that we couldn't translate properly. We think they might be relevant, so they're just pending. What you would hope is if you've got 40 papers in your review, that those 3 aren't going to say anything very different. And in fact, what we did do with the antenatal review is that because it took so long to get published, because it takes so long to get things published, we actually did an update between the initial review and the second review, and we used that update as a confirmatory check. So papers that have been published since we did we produced our findings, did they say anything different to the ones that the findings we had? And in fact, they didn't. So we were very confident in our findings. And you can do the same thing when you finally get your difficult to translate papers translated.
Very good. Sue, another question in relation to the Western approach going into African countries and encouraging people to use antenatal systems and filling then the regional hospitals with people who are coming for antenatal care. I mean, do you think that we, even as midwives, have actually been guilty of losing sight of normal birth or physiological birth and have moved people into a more technical managed birth? Do you think we've done that? Do you think we're guilty of that? Some of us, not personally, though.
Yeah. Oh, I think we've all done that. I've done that. I've definitely done that in practice where I've done things either because the guidelines say, even though I've not, and guidelines as in used as protocols, and I've not had the courage to challenge it, or or where I haven't noticed that something's happening, or where I've not. The example I usually give on this is actually a very early one where I fairly newly qualified. This Marley and I go back a long way. This is a long time ago. A long time ago.
Netting the Smoke was brilliant in 2007. Brilliant.
I have to say, Marlene, you look very beautiful though. I meant to say that to you before.
Thank you very much. If you see me, thank you.
but so this was, I newly qualified, not much courage. At the time, we didn't really ask consent from women, we just did stuff, and we gave women pethidine willy-nilly. So this particular woman had, she was a grand multip. She was obviously in some kind of pain, but she didn't speak English. So I did a multips os. I did a vaginal examination. She was a multips os. So I trotted off to get the pethidine, like you did. I didn't ask her. I just went and got the pethidine. Came back with all eager-eyed and bushy-tailed as a new midwife with the pethidine, and the baby was in the bed. And I'm like, so I think even when we, even if we're not doing things that are obviously going to be constraining women's situation, there are always going to be women who do things that are completely outside of any kind of limits that you might imagine, and we just have to be sensitive to that. And I think we often are not, because we're so constrained. We're not courageous enough, or we're not, sometimes not compassionate enough, or we're just kind of too knackered.
It's a very important discussion, and I'm just checking if there are any more questions, folks. Are there any more questions? I'm just keeping an eye on my phone here for Sue. If there are any more questions from anybody, if you could put them into the text box, and then Paul will send them on to me. And because we're going to run out of time, what we'll do is that if Sue doesn't mind, if we can send you a couple of questions, if it's possible for them to respond to them, because the work that you're doing is phenomenal, and it's going to have a massive impact in relation to the antenatal and the postnatal care, because it is very challenging, and I'm delighted that it's done, and we'll be using it in our Birth Across Borders project, and some of my colleagues who are involved in that study were just starting it in Myanmar, working to try and to have some sort of an impact on maternal and infant morbidity and mortality. So it's very timely having this presentation today, and very challenging as well. But so there are no more questions. So it leaves me just to say thank you very much, Sue.
Thank you, Maureen.
Love you. Absolutely brilliant.
Thank you for
Thank you very much. Thank you.
And of
Thank
course,
you.
all of our work as a group is everybody. You know, it's not just the whole group of us. Yeah.
Thank you very much, Sue. Take care. Keep well.
Yeah.
Folks, we're at the end of this session.